Esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2024. My name is Michał Macner, and I have an honor of moderating the Anesthesiology, Intensive Care and Emergency Medicine session. I would like to cordially welcome the esteemed jury, President of the jury, Professor Piotr Knapik, Professor Łukasz Krzych, who joined us online.
Dzień dobry.
Associated Professor Piotr Czempik, Dr Konrad Mędrala, and Dr Małgorzata Łowicka-Smolarek. Now, I'd like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximum time for the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. These assessments will be verified. Due to the regulation of our Congress, all the presentation and discussion must be run in English. If the Commission will ask the question in Polish, the authors of the work are obliged to answer in English. I kindly ask the jury to assess scientific value, way of presenting, discussion, and of contribution. From each category, you can get 1 to 5 points. When the session ends, I will take the cards from the jury. I think we can start with the first presentation, which is controversies in prioritizing patient qualification for treatment in intensive care units.
All right. Controversial decisions are made every day by politicians, by celebrities, even by the football referees. But are we able to avoid such decisions in the hospitals? Dear scientific committee, dear colleagues, my name is Wiktor Wagner, and I would like to present you our work of me and my co-authors, the controversies in prioritizing patients' qualification for treatment in intensive care units under the supervision of Professor Łukasz Krzych. So what are the 4 pillars of a decision-making if the patient should or should not be admitted into the ICU unit? Firstly, patient's factors. The patient's condition, the patient's wishes. Secondly, resources factors. The amount of beds in the ICU unit or the accessibility of the equipment. It's very important. There are clinician factors, for example, the experience of the doctors, the knowledge of the guidelines, or even the doctor to the patient ratio. And there are other factors, such as the time of the admission. And for the guidelines, in Poland, we're using the guidelines of Polish Society of Anesthesiology and Intensive Therapy, published in 2022. These come with an extensive form to fill out, containing plenty of factors and biological conditions and biological factors of a patient, which are to help the doctor decide if the patient suits the intensive care unit. And despite its existence of those guidelines and these forms, the decision if the patient should or should not be admitted into the ICU unit are sometimes poor or made too late, thus worsening the patient prognosis and condition. And these are due to, for example, moral or medical doubts of doctors. And the aim of our work was to assess which factors and which clinical scenarios are especially hard to decide and which are easy to decide, thus possibly marking the spot which should be considered more closely. We collected our data due to an online questionnaire where the anesthesiologists answered a question using a 3-point scale about the importance of biological factors of patient and about clinical scenarios. The questionnaire was published on Medycyna Praktyczna page in a section of anesthesiology and intensive care. And we collected 133 responses, including 121 specialists. The median working time was 10 to 15 years, and the mean working time was 13.35 years, which means that our respondents were experienced doctors. The main working place was municipal or district hospital, 45.1%. And as for the results, here we were assessing the conditions and biological parameters and if they are important. Doctors were answering if this biological factor should or should not be taken under the consideration during the ICU admission process. And as we can see, prospects of reversibility or organ failure are almost 97% doctors agreed that it should be taken under the consideration. It's the highest rate among all the factors. Degree of advancement of chronic disease, liver and lungs dysfunction, and degree of dementia were also all above 90% agreement that these are the factors that should be taken under the consideration. However, there are some factors which were not as easy to assess. For example, the BMI was the most problematic one because 1/3 of doctors thought that this factor shouldn't be taken under the consideration. 20% didn't have a strong opinion, and only about 50, not 50% said that it should be taken under the consideration. Similar results were in the Apache scale and age, which also were not as agreeable among the doctors. And for the clinical scenarios, this is where the most problems begin, because where there are some scenarios where when the answer is easy, for example, acute respiratory failure due to asthmatic status, 90% of doctors thought that obviously this is the case when the patient should be admitted into the ICU. There are some scenarios where when this wasn't that easy, for example, rejection of or exhaustion of transplanted organ, 45% of doctors didn't have a strong opinion, or the opinion was ambiguous, and that's a really high rate. Same here. There are some when the doctors were very sure that the patient should be admitted. For example, patients with fatal brain damage, then stage of degenerative or demyelinating disease, or patients with a minimate status of consciousness. Again, 85% or more of doctors were agreed that these patients shouldn't be admitted into the ICU, that the admission into the ICU won't help the patient. However, again, surgical implications without the possibility of implementing causal treatment, chromosomal aberrations or stroke were scenarios when the rate of uncertain answers were above 40%. What is more, the surgical complications is especially interesting because 40% of doctors didn't have a strong opinion, 30% said that this patient should be admitted into the ICU unit, and 30% thought that this patient shouldn't be admitted into the ICU unit. And as for the conclusions of our work, the decision about the admissioning the patient is very often made under the huge amount of stress and in a very short time. Thus, anesthesiologists should advocate for an increased standardization of guidelines, especially in the cases when the uncertainty and ambiguous answer arises. What is more, in those cases when the patient's condition is hard to assess, the doctors could consider could consider holding a specialist council containing not only anesthesiologists, but also other specialists to assess the patient's condition and to decide if the ICU unit is the proper place for a patient. This is the literature we used during our research. Thank you all very much for your attention. We'll be happy to answer all your questions.
Thank you very much for your presentation. And now I'd like to start the discussion.
Because you are obliged to have your presentation in English, I think it will be appropriate for us to ask the questions in English as well. First of all, it would be nice to have one microphone here in this part of the room for this part for this time. First comment which I have is a technical one. If you are showing the complex graphs, complex figures, you should make the fonts much bigger, because it was very difficult from here to see what is there. Generally speaking, it's you should avoid. It was a nice presentation and a very nice study. You should probably avoid the conclusions that something is difficult, and it's difficult to say, well, it's as it's said here, our results show that the decision making during qualification is difficult, and that's a problem even for an experienced doctor. You should point one single issue that is that may be found from this study. What do you think? What, apart from the fact that it is difficult, what do you think is a single issue that a single strong message that comes from this study? What is your opinion?
Thank you very much for the comments, for the tips, and for the question. We believe, with me and my co-authors, that the main thought behind the study is that in the case scenarios when the amount of uncertain answers is the highest, the guidelines for the anesthesiologist should be made clearer, or possibly the standardization should be implemented, because this would benefit not only the patient but also the doctor, to help decide, to make a clear decision that the patient should or should not be transferred into the ICU unit. Thus, basically the improvement of the guidelines in the cases when there is a huge amount of uncertainty.
A very nice presentation. So you said that there should be some kind of standardization of admission to ICU. The question, I think, is a very open question, because the topic is very controversial. Either the guidelines should be more strict or more liberal, and based on maybe some time-limited trial. So you have a patient which is questionable to qualify to the ICU, so you can admit him, treat him for several days, I don't know, 3-4 days, and then decide either the patient should be treated for a long time, or maybe the treatment should end as the
Thank you very much again. We believe that I believe with my co-authors that the guidelines should, when there are cases with a strong ambiguity, for example, the stroke, when there was about 40% of uncertain answers, the stroke scenario should be divided into the smaller scenarios. For example, stroke, but the overall condition of a patient is okay. Or, for example, the stroke, but the overall condition of the patient is not so good. And thus, by the diversification, it would be easier to make a decision for a doctor. Of course, there are a lot of not only medical problems, but also moral problems and equipment problems, as I said in the introduction. But I think that the guidelines should be more, that there should be, in the hard cases, in the cases when there are problems, the diversification and showing more little scenarios of a big scenario could be beneficial.
Thank you very much for your presentation.
It's working now. So because, well, were the responses of respondents like striking for you? I mean, were they surprising to you? Are any factors that are either should be taken or not taken into consideration when deciding on admission to ICU? Were these responses surprising to you? Some of them or none of them, or are there any that were surprising to you?
When we prepared our work, we obviously researched the guidelines of Polish Association of Anesthesiology and Intensive Care very carefully, and the main message of it are that the transmission into the ICU can be considered if the patient's problem is reversible. That's the main thing. And thus, the results were pretty astonishing, because some are easy to assess, but the fact that, for example, the stroke, I would concentrate on that, was the 60% of doctors 40% of doctors didn't have any opinion, or the opinion was ambiguous. That was striking, and thus we believe that the creation of stronger and more specified guidelines can be considered. But overall, yes, the results were pretty, for me at least, astonishing, because maybe before the preparation of work, I thought that it is easier, but it's obviously not.
And could you go back to the slide where you have BMI and age as the factors that should be considered or not when deciding? There is a BMI, yes. So this was the questionnaire, online questionnaire, and BMI and was one of the factors that should be considered. But we don't know if this was a minimal, BMI below or above. For me, BMI, in general, is ambiguous as a response. I didn't know what to decide. For example, I wouldn't take into consideration, and I would take into consideration highly decreased BMI, but I wouldn't take into consideration. I wouldn't take into consideration higher than normal BMI. Yes. So to me, BMI as a response, without specifying, is it BMI below certain level or above certain level? To me, it would be ambiguous, because I wouldn't know what response to give. And to me, it's also striking that so many age is not under should be taken into consideration. To me, age shouldn't be taken, because we don't. The age is chronicle age shouldn't be the decisive factor. Just biological, the condition of the patient. Yes. So the responses are striking to me. And the last thing, because we are obliged to judge you on your contribution. So if I may ask every team to just mention what was your contribution, so we don't have to ask it again and again. Okay?
Okay.
Thank you.
Okay.
And Professor Knapik has some remarks.
But first of all, you should probably answer this question.
Okay, so really fast. First, the BMI. Yeah, that's very large, because it can be very low or very high. But that's why there is, for example, massive obesity as other factor. And that we asked about the BMI because in the forms I showed in the start, there is a BMI, and that's why we're curious if the doctors think that this is an important factor. The age, yeah, this is why also we implemented the yeah, there was age about 80 and there was a biological age here. Yeah, okay, that will be an improvement for the future. And as the contribution of me and my team start the research of many papers on the topic on the ICU admission, the creation of online questionnaire, the process of publishing it online, then collecting the data and working on the data and presenting in this form. That was all made by us under the supervision of professor.
The last question is, it just came to my mind that I have to ask you this question. Are you aware of the fact of the background? Are you aware of the problems that generally intensive care units in Poland have? Do you know anything about the because that is this issue is associated with the admission process, right? And do you know anything about the mortality in Polish intensive care units in comparison with the Western countries or whatever? Do you know anything about that?
I'm aware of some problems in the ICU units, for example, the lack of specialists and the sole amount of the ICU units, which are very often not enough because there is the problem of admission is connected with the fact that we often can't transfer the patient into the ICU unit who maybe should be his. This is a controversial decision because the patient could be transmission, but we don't have enough beds, so we must decide if this patient's condition is enough to transfer him or not.
Well, you are absolutely right, but it seems that you are not fully aware of what the situation is, and that is also a message for you. Polish intensive care units, according to some recent studies, have very high mortality in comparison with all the Western countries, probably the highest in that part of Europe. And it has been very well shown that this is not associated with the fact that we are not treating the patients properly. It's associated with a hopeless prognosis of patients on admission. That's why we are not admitting proper patients to Polish ICUs, and this is a general problem in this country. That's why this issue is so important. You should be aware of this fact, progressing with this study further. No?
Yeah. Well, we have in plans to progress the study and to assess, for example, the place of the where the doctor is working, the type of hospital with the answers. It's a project for the future. Thank you.
Thank you very much for the discussion and for your presentation. The next presentation is why do we decide to heal death? Futile therapy in critical ill patients from the perspective of anesthetists, questionnaire study.
Ladies and gentlemen, why do we decide to heal death? Although this question may seem controversial, it opens very important discussion about issue of futile therapy. My name is Michał Wilk and I have honor of presenting you our survey study created jointly with my colleagues Antoni and Małgorzata under the supervision and guidance of Professor Łukasz Krzych. The prevention of futile therapy in the ICU departments is described in guidelines created by Polish Society of Anesthesiology and Intensive Therapy from 2014. It describes this issue briefly and also delivers to the physicians templates of documents that could be used while applying the protocol. The intensive care is one of the most rapidly developing fields of medicine, with new artificial ways to replace the organ function of the patients, but with great possibilities even greater responsibilities comes. In some patients, organ failure cannot be permanently cured. In those patients, utilization of invasive procedures could enhance the patient's symptoms, like pain, and deprive them from dignified death. In our study, we sought to investigate the perspective and reflection of Polish anesthetists on this issue. We also wanted to assess factors, both hospital factors and personal factors, that may influence answers of our responders. We conducted anonymous online survey study through an online platform in first quarter of 2024. We gathered information from 113 anesthetists. For further investigation, we selected a group of 51 anesthetists who are working on the ICU department more than 33% of the working time, the ICU with at least 6 stations, and ICU that applies the protocol mentioned earlier. The factors that we examined were type of hospital, stage of specialist training, experiences regarding futile therapy concerning a close individual, close friend, or family member, religious practices, and parenthood. Results. The implementation of futile therapy protocol was statistically correlated with type of hospital in chi-square test. The most frequently, the protocol was utilized in university hospitals with 91%. Then, in provincial hospitals with 76%, and least in city hospitals with 60%. We asked our responders which procedures that are performed on the ICU should be considered regarding the implementation of futile therapy protocol, either withholding or withdrawing. The most frequent answers were usage of ECMO and renal replacement therapy, both 100%. Then CPR and usage of vasopressors. As you may see, those answers were not statistically correlated with personal factors mentioned earlier. Then we asked our responders from which procedures they can withdraw once introducing it in their workplace. The most frequently, they pointed out CPR, renal replacement therapy, usage of vasopressors, and ECMO. Still, no correlation with personal factors was observed. Time-limited trial therapy is a procedure that is very helpful for physicians to estimate the patient response for the treatment and further prognosis. We asked our responders both about implementation of this procedure in workplace and their personal opinion. The most frequently, they answered that they are not currently using this procedure in workplace, but they think it should be introduced. The 35% of our responders answered that they are using the time-limited trial in futile therapy context, and they think it justified. The careful and insightful examination of patient state is a crucial part of futile therapy protocol. We asked our responders which patient factors should be considered regarding the futile therapy protocol. The most frequent answers were extent of neurological damage, the functional status before admission, and degree of compensation for chronic diseases before hospitalization. The futile therapy issue still persists. We asked our responders, in their opinion, which factors may contribute to this occurrence. The most frequent answers were fear of legal consequences, with 88%, personal, moral, and ethical dilemmas of physician, and the pressure of family member. No correlation with factors was observed. The issue of futile therapy on the ICU departments persists. There is a strong need for updated guidelines that would take into account both reflections and needs of Polish anesthetists. That guidelines may include topics like time-limited trial and clear analysis of legal status. Enhancing the utilization of protocol, especially in city hospitals, may facilitate the physician's work and also elevate the standard of the patient care. And last, as we observed, the personal factors didn't influence our responders' answers. That may suggest their professional and impartial opinion in this hard topic. Thank you for attention.
Thank you very much for your presentation. And now it's time for the questions.
Okay. So this time someone else should be first.
Thomas, I need to.
I have just one question about the data flow chart. It was, I think, slide 3rd. So you can
Which topic was that?
about the qualification, the eligibility criterion. So why you have chosen the 6-bed ICU? The first question. Why this?
Okay, it's about this slide.
So first of all,
Yes.
you have 113 patient anesthesiologists.
Yes.
So and you analyze only 52. What about the rest population? Have you tried to analyze what happens in this?
So in this slide we took 110 anesthetists. The 3 of them was declined because they chosen the other type of hospital, and we have those standards. But we didn't mention the 51 persons anesthetists. It was hard decision, first of all, because it's big population of persons. But we wanted to gather information from anesthetists that deal with this issue on a daily basis, and they're in touch with this problem. Some of anesthetists may work more on the operating theater, and maybe their knowledge about it and personal experiences is not that great as the anesthetists that work more on the ICU and less on the operating theater. We wanted to get a first contact anesthetists that deal with this every day, and that was our decision. It was a hard decision because we lost in some kind of way half of our responders, but we wanted to get insight of this problem for the first hand.
Okay, and what about the one patient which was not analyzed? Because it was
so in our questionnaire, this responder chose an answer that was contributed to each other. So he chosen that they are using the futile therapy, and in other question it was made that they are not using it. So it was
yes. Yeah, I've asked about it because if you present this kind of graph, it should be very precise why you included or excluded the patients and why you didn't analyze the one patient. Okay, because there was no
it's not so specific. We said only due to inconsistency, we should make it more clear and precise. Yes, that's right.
Well, first of all, I would like to congratulate you for the conclusion number 1. This is the most perfect that I have ever seen. There is a strong need for update of the guidelines. I fully agree with you. We should update the guidelines from 2014 as soon as possible because they are very important.
They are very brief.
Yes, but apart in that type, imagine you are asking the respondents a very difficult question, right?
I agree.
If you are asking a very difficult question, you should know, you should take into account that some of the responders will be willing not to give you a response at all because this is more convenient for them. Do you have therefore, I would like to ask you how many questions have you sent, and do you have any information of how many people were not willing to give a response at all?
So it's a bit hard because it was online service, so we didn't notice how many people received this. We also published it on Medycyna Praktyczna page. We didn't know how many, but I will agree with you, Mr. Professor, that some of them won't be willing to answer because it's very hard questions and very difficult topic on different levels, medical, but in ethical, moral, maybe religious. So I don't have specific data, but I think it will be significant portion of response.
So I would like to tell you something that might be very interesting. I was doing that kind of questionnaire in 2015, 1 year after the guidelines have been published. But at that time, I have been sending a questionnaire to the named individuals, to all the members of the Polish Society of Anesthesiology and Intensive Care in the located in the university hospitals. And you know what? I received only 8% of responses. The remaining people, they didn't want to give an answer at all because that topic is so difficult.
What was your contribution? Did you say that?
Of course. So as I mentioned at the beginning, every step we're working together, but if I had to choose specific parts that we are mainly engaged, I was doing the presentation and statistical evaluation, and my colleagues, Małgosia and Antoni, they were preparing the questionnaire and sending it to the doctors and gathering information and preparing it for statistic evaluation.
And by the way, it's chi-squared. Chi-squared. That's how you pronounce it. Okay.
Thank you very much for your presentation. The next presentation is titled Ventilator-associated pneumonia in critically ill patient, single center experience.
Dear jury, ladies and gentlemen, my name is Jakub Rudzki and I'm honored to present you our work about ventilator-associated pneumonia in critically ill patients with subarachnoid hemorrhage. So, majority of patients with subarachnoid hemorrhage in severe state require mechanical ventilation for a prolonged period. Unfortunately, in neurocritically ill patients, it carries an increased risk of developing pneumonia, so-called ventilator-associated pneumonia. It may be because of the brain injury-induced immunosuppression syndrome with subsequent susceptibility to infections. These two conditions combined can later serve as a real problem and endanger to the patient and increase the risk of mortality. So the cutoff point for the differentiation of VAP is 7 days. Before day 7 of mechanical ventilation, we are talking about early onset VAP, which is more likely caused by non-multi-drug resistant bacteria. And after day 7 of mechanical ventilation, we are talking about late onset VAP, which is more likely caused by multi-drug resistant bacteria strains and often require broad antibiotic therapy. Broad spectrum antibiotic therapy. But why does it happen? Well, there are no certain risk factors of VAP in SIH patients group, but there are some which are linked with an increased occurrence of VAP in this group. And these are prophylactic hypothermia, which can impair the proper function of immune system, making the patient vulnerable to infections, microaspiration of gastrointestinal contents, which may happen during intubation process of unconscious patient or with a sudden loss of consciousness. Then we have earlier tracheal colonization, as well as high doses of enteral nutrition, older age, treatment with mannitol, and tracheobronchitis. So we aimed to assess the prevalence of VAP. We aimed to identify its etiology and investigate the role of bacterial colonization of the respiratory tract in critically ill patients with SIH. So we conducted a single-center retrospective observational study from beginning of 2019 to 10th of 2021. We analyzed the demographic and clinical data, as well as method of collecting material from the respiratory tract and results of laboratory and microbiological tests. Our group consisted of 58 critically ill patients with SIH, of which 11 were later excluded due to lacking bronchoalveolar lavage or endotracheal aspiration results, and we were left finally with 47 patients. So now moving to the results section. As you can see, our study group consisted almost equally of men and women. The median age was 52 years. The median Glasgow Coma Scale on admission was 6 points. Main cause of subarachnoid hemorrhage was ruptured aneurysm in 85% of cases, and followed by arteriovenous malformation and trauma. Almost every patient was intubated on the ICU admission with a median time of mechanical ventilation of 8 days. And as you can see, based on Fisher and Hanhes scale, our population consisted mostly of patients in severe state. So here you can see the bronchoalveolar lavage and endotracheal aspiration results taken on admission. When it comes to bronchoalveolar lavage results, you can see a variety of bacteria strains as well as sterile samples with no dominant strain of bacteria. And when it comes to endotracheal aspiration results taken on admission, the most common one was physiological flora, followed by Staphylococcus aureus and Escherichia coli. Only 2 strains were multi-drug resistant, which was screened on the admission to the ICU. So bronchoalveolar lavage during ICU stay was performed if the attending physician was worried that the patient were developing pneumonia. So if the patient's condition were deteriorating, the symptoms signalized that the patient may have been developing pneumonia, the BIL was made. And the most common pathogen isolated was methicillin-susceptible Staphylococcus aureus with Klebsiella pneumonia, both of which had 6 cases. And 4 strains of Klebsiella pneumonia were multi-drug resistant, as well as multi-drug resistant bacteria were Enterobacter cloacae and Actinetobacter baumannii. So as you can see, the characteristics of VAP patients, which was diagnosed in 9 cases of our study population, the mortality in VAP patients was 2-fold higher than the patients without VAP. The median time from admission to diagnosis of VAP was 3.5 days. None of the patients with VAP was liberated from the ventilator, and multi-drug resistant bacteria were responsible for 33% of early onset VAP cases. So did we find any risk factors in our study population where after identifying and analyzing such parameters such as sex, neurological status, age, or treatment or no treatment method, we did not find any risk factors in our study population. None of it was statistically significant. So now moving to the conclusion section, the prevalence of VAP in our study group was high, but not as high as other authors' reports, up to 75%. Klebsiella pneumonia and Streptococcus pneumonia were the most common etiological factors of early onset VAP. And patients with early onset VAP often showed no previous colonization with multi-drug resistant pathogens, which suggests that the cause of infection were bacteria acquired during hospitalization. Thank you very much for your attention.
Thank you very much for your presentation. And now I open the discussion.
I have one comment regarding exclusions.
Yes.
Because if you have a study consisting of, I don't remember exactly 50 something.
58.
58 patients.
Yes, exactly.
And you exclude 11 patients.
Yes.
From that, so you are not able, well, you are able, but you are not able to assess fully what was a real prevalence.
Yeah.
Because you have because you have a prevalence in this subgroup, right? Not in the whole group. You may have a VAP in the other 11 patients quite easily. Also, I have some doubts about the use of the, well, not about the use, but the fact how strong are the correlations in the group of 47 patients. It's not well. I'm not surprised that nothing has been statistically significant. And just if you could make it clear, what criteria did you use for the recognition of VAP?
So to the recognition of VAP, we used presenting right there the criteria defined by Centers for Disease Control and Prevention, which require the symptoms, clinical symptoms in patients that are with a new onset, laboratory findings, which means that, for example, in bronchoalveolar lavage, there were some bacterial cultures present, and as well as new radiological findings, which have a progression present. And of course, I am fully aware of that. Our study group is rather small, and we should not be taking, or rather, our conclusions should be taken with some, some distance, because to like have a proper and very quality conclusions, we should have like not 47 but 470 patients, for instance. And I'm fully aware of that. But thank you. Oh yeah. So I was mainly engaged in this work by creating a presentation and presenting it.
Do we know anything about these patients who have this multi-drug resistance bacteria? Pathogens? Do we know any risk factors, like previous risk factors for this multi-drug resistant pathogens?
As you can see, we analyzed these factors, and every patient on the admission was screened if they are a carrier of multi-drug resistant bacteria by a rectal swab. No patient in our group was a carrier of multi-drug resistant bacteria. No patient was present with some sort of respiratory tract symptoms on admission. So the data suggests that patients had no previous history of like being a carrier of multi-drug resistant bacteria. And this is all the data that I have. As you can see, the patient with multi-drug resistant Klebsiella pneumonia on admission had no growth in bronchoalveolar lavage or endotracheal aspiration. Another patient with multi-drug resistant bacteria was presented with physiological flora on admission. Another patient with VAP with multi-drug resistant bacteria had physiological flora. So all the multi-drug resistant bacteria were acquired during hospitalization and mechanical ventilation in the ICU.
Unfortunately, yes.
And there's only one thing that I've just noticed, that you stated in the abstract that you have very high mortality, approximately 67% from the VAP. It's just here stated that you have 62% mortality in hospital mortality in the VAP patients.
In VAP patients, yeah.
So if you calculate, if you do the math, 62% from 9, it's 5.5 patient. So
okay.
I think that there's a bit mistake in the calculations. Okay, so you have to change it. Okay.
Thank you.
Thank you very much for your presentation. And the next presentation is pain management in pre-hospital care using opioids, a continuing debate between healthcare professionals.
Good morning, ladies and gentlemen. My name is Agnieszka Jączyk, and I'm going to discuss the findings of our research on the pain management in pre-hospital care using opioids, a continued debate between healthcare professionals. The opioid analgesics, the first step to pain management or the first step to addiction. It is important to understand that opioids play a crucial role in pain management. Their action is rapid and effective. However, they carry risk for addiction and respiratory depression. Mass prescribing of opioids in 1990s led a health crisis in the USA. The number of drug overdoses in deaths in 2021 was more than 6 times higher than in 1990s. So, where is the middle ground? The focus is on the patient, who has the right to safe and effective pain treatment. We have seen a significant decrease in the number of doctors in emergency rescue team over the past 8 years. We aim to assess opinions of healthcare professionals on the effectiveness, frequency of use analgesics, including opioids, in the daily professional care. We explore differences in understanding of safety among different professional groups. We analyze was based on 134 respondents, 52 specialists and residents in anesthesiology and intensive care or medicine, emergency medicine, and 82 paramedics or nurses in system, using a website questionnaire featuring Likert scale items. The data was compiled by statistic program. Statistical significant differences were indicated by determining if the p-value was lower than 500. The questionnaire was designed to assess the experience with different approaches to pain management. It including questions regarding the completion to additional training, satisfaction with acute skills during studies, and frequency of analgesic uses. Initial results showed statistical differences related to satisfaction with the skills acquired during studies in regards to opioid pain management. Paramedics and nurses reported greater satisfaction with the outcomes of their education, but they participate less frequently in additional training. Physicians were more likely to use multimodal therapy. In doctors' group, 75% of responses use co-analgesics very often, compared to another group where the same answer was about 27%. Physicians often highlighted a lack of competency and the addiction risk as a significant barrier to opioid administration. They also reported respiratory complication following opioid administration more frequently. Notably, majority of medics agreed that opioid analgesics are very necessary tools in their daily professional work and acknowledge them as safe and effective medication. We asked 2 more controversial questions regarding the sufficiency of competency for self-administration of opioids by paramedics and to expand the panel of available drugs. The results are not conclusive. The majority of paramedics consider their skills as sufficiency, but the doctor's opinion are divided. Similar results apply to expansion of the drug panel. So let's treat this question as the first step in this topic and open the door for the future research and discussion between paramedics and doctors. Conclusion. The study highlights the existing differences in approach of healthcare professionals using opioids in prehospital care. It is important to raise the standard in teaching of pain management using opioids. Future investigation into the role of opioids in Polish prehospital care and establishing guidelines in the simple use of are necessary to ensure safety and effective pain management. That's the research. Thank you very much.
Thank you very much for your presentation, and it's time for the questions for the committee.
I have one small comment for you for the future. During your presentation, it's not anything that has to do something with the contents, but you shouldn't use additional support. Your slides should be for you enough to guide you what to say. I would like to, but this is not about the scientific content. There is a how would you comment, because this is a very interesting thing that the paramedics and nurses expressed greater satisfaction with the skill they acquired during their studies than doctors. How would you comment on that?
I think that I'm studying like doctors, and I think we haven't got enough lessons about pain management. We don't know about the doses. We don't know how we used to look after with chronic and acute pain. I spoke with my friends paramedics, and they have much more lessons about this topic.
What do you mean about what does exactly mean the self-administration of the opioids? Because on the slides was self-administration, so I presume that's
yes. Because, for example, the fentanyl, we like doctors can use by use the other way, not the vein, but with nose, then in nasal dose, and the paramedics can't do this.
Okay, thanks.
Thank you very much for the discussion and for your presentation. And now important information for our committee. The presenters of the fifth presentation resigned. So let's move to the sixth presentation, which is risk factors for gastric mucosa erosion in the ICU patients with PEG receiving prophylactic treatment.
Good morning, everyone. My name is Jan Osicki, and I'm honored to present you our group's work titled Risk Factors for Gastric Mucosa Erosion in the ICU Patients with PEG Receiving Prophylactic Treatment. Firstly, a few words of introduction about PEG, which stands for percutaneous endoscopic gastrostomy. And this is a very safe method for providing nutrition for often malnourished patients in ICU, as they can't eat by themselves. And it's been proven safer than other methods of enteral feeding, like gases, like like nasogastric tubes, showing lower risks of aspirational pneumonia and gastroesophageal reflux. And now a few words about proton pump inhibitors, which I will refer as PPIs in my presentation. Those are one of the most commonly prescribed medications in the world. And they found its use also in ICUs, as they can be used in prophylaxis of stress ulcers, which develop quite often in ICU wards, and in prophylaxis of peptic ulcer bleedings, as they help with platelet aggregation and clot stabilization by making pH higher. And the aim of our study was to assess the current prevalence and risk factors for gastric mucosa erosion in ICU patients receiving standard pharmacological prophylaxis. To achieve our aim, we conducted retrospective case control study. We studied the population of patients from ICU in UCK Katowice. The study period was from the January of 2020 to December of 2023. And every patient included in the study had PEG insertion. After completing the database that we retrieved from electronic medical records, we compared continuous variables using Wilcoxon-Ransom test and binary variables using Fisher exact test. Our study flow looked like this. We registered the total of 161 patients, and after defining the standard pharmacological prophylaxis as 40 milligrams of PPIs per day, we set our exclusion criteria as higher doses than that and lesser doses than that. And that eliminated 7 of our patients, and the remaining 154 we divided into cases with gastric mucosa damage and controls without it. We defined gastric mucosa damage as occurrence in our patients one or more than one of presented conditions. So simply, if we found in our medical records ulcers, erosions, effusions, or bleeding, we categorize such patient as a case. Our patients were rather elderly, a bit overweight with a median BMI of 26, and the median ICU length of stay was 22 days. And we had slightly more men than women, with 62.3% of men. We analyzed the total of 23 risk factors and divided them roughly in 2 groups. First is concomitant diseases, from which the most popular were acute kidney injury, diabetes, and coronary artery disease. Other risk factors varied from different medications that our patients were taking, like corticosteroids, NSAIDs, low molecular weight heparin. And our risk factors was also sepsis and mechanical ventilation. And out of 154 patients, 48 presented with gastric mucosa damage. And unfortunately, 22 of our risk factors showed no statistical significance, with p-values showed on the slide. And our only risk factor significantly different between groups was history of ulcer disease, with p lesser than 0.01, with odds ratio of 17.9 and 95 confidence interval. Now coming to conclusions. The majority of classical risk factors do not predict gastric mucosa erosion detected endoscopically in ICU patients receiving standard pharmacological prophylaxis. History of ulcer may be the only risk factor predicting ulceration in patient population, and patient with history of ulcer disease may benefit from large doses of gastroprotective medications. thank you for your attention, and I'd like to mention my contribution to the work. I've been collecting the database, editing the database, and I've been helping with making this presentation. And last but not least, I've been honored to present to you today.
Thank you very much for your presentation. It's time for the questions.
I would like to congratulate you. It's for the quality of the research that has been done, because it's a decent number of patients with the insertion of PEG, really a decent amount, a number that I think this paper is actually ready for further publication probably, because you have lots of data. You have shown us a nice graph of the flow chart, which is a very appropriate thing in that kind of study. So the quality of your work is really nice. The results may be a little bit disappointing for you, because most of the factors have not been proved to be significant, but it doesn't matter. It's with that number, it was a little bit predictable. But generally speaking, I think you should do something more with your study, just on the top of leaving it on the level of this conference. You should go further with that. Or probably increase the number.
Yes, we are planning to do so.
That's a suggestion for you as well.
Yes, we doesn't jumping already. We are planning to make a slightly bigger group and pursue the aims further.
I have just one suggestion, maybe, because it's very good study. But if you deal with some risk factors, it's very tempting to use logistic regression as a tool to assess the influence of these factors to the endpoint. And if you see the p-values of the future test and the Mann-Whitney test, there are some factors that can be included in the multi-variable model of logistic regression. So I think that it will be very good to go a step further to reanalyze the results, including some of the factors in the multi-variable model. Okay, because if you can just 2 slides. Ariel, yeah. So as you can see, the BMI, also the fibrinogen maybe, or the ALI. There are a lot of, I think, risk factors that could be not the risk factors by themselves, yeah, but something that modify the odds ratio of the major risk factors, so the peptic ulcer in the past medical history. Okay, so if you want to publish it, it's a very good idea, but I think that there can be done something more with the statistics to show everybody the full spectrum, the full model of the risk factors. Okay.
Okay, thank you. We'll surely take this into consideration.
May I ask 2 questions to the presenters? I see 2 drawbacks regarding your study. It is according to what was previously seen in your slide. First of all, you didn't take into account time frames for PEG insertion, and I think that this is one of the issues that should be taken into account if it was maybe too early or maybe too late, and maybe the predisposing factors in these patients are very important and more important than CRRT. I can't see any relationship between all those variables that you took into account. it's some kind of fishing in the statistical point of view. Those things that are discussed by you are not really risk factors. And the second point is that you should maybe make a comparison with feeding tube. Is there any difference between PEG and typical long-term feeding tube in terms of complications?
Yes, we have a lot of risk factors because we retrieved our data from medical records, so we had we could see them all at once. So that's why we decided to choose such a variety of them. And about nasogastric tube, we used only patients with PEG because during PEG implantation we can assess patient stomachs and duodenums because the esophagogastroduodenectomy is compulsory while inserting PEG. So that's why we used such patients, because we didn't have to make any additional examinations to patients, and it was also significant because it was retrospective study. So if we wanted to examine the patients from 2020, we would have to get them somehow. And using PEG patients, we had everything in the system.
So it should be better for you if you perform a prospective study, because you don't know the real impact of acute lung injury or even other complex conditions that occur after hospital admission. You don't know what is the type and the extent of those clinical conditions. So maybe it should be better to focus on patient-related factors according to demography and according to those baseline factors, then to use all those influencing factors which should be taken into account in a more complex analysis, as Konrad Mendrala said.
Okay, thank you for your remarks. We will try to investigate this matter in the future.
Thank you very much for the discussion and for your presentation.
Thank you.
And it's time for the next presentation. It's titled Urinalysis Parameters in Detection of Culture-Positive Catheter-Associated Urinary Tract Infection in Patients.
So, hello everyone. My name is Xavier Adamiec, and I'm a fifth-year medical student from Medical University of Silesia. As you can see on the screen, we did a study which aimed to see if the urinalysis and selected laboratory parameters in detection of culture-positive catheter-associated urinary tract infection in patients hospitalized in the intensive care unit, quite a mouthful, I would say, if there is any correlation, if they can be used to assess that. Our works tutor was Docent Piotr Czempik. So I've divided my presentation into 5 sections, which are introduction, materials and methods, results, discussion and conclusions, and lastly, sources. Well, let's start at the beginning. I'm going to be covering some key informations you need to know before we can start and go to the results, of course, obviously. So, what is COTI? COTI is a catheter-associated urinary tract infection. It's a pretty common type of infection that occurs in patients who have a urinary catheter put in place for at least 48 hours or longer. The diagnosis of COTI can be quite challenging due to many factors, such as the inability to communicate with the patient and non-specific symptoms. Well, we analyzed data of patients who had urine sample taken simultaneously for urinalysis, as well as microbiology, urine microbiology. We have also analyzed data of C-reactive protein, procalcitonin, and other factors such as BAN and urea. Let's talk a little bit about materials and methods that were used by us during this study. So all data was collected, was acquired using the AMS system at our university hospital, and then kept within an Excel spreadsheet. So for statistical analysis, I've used a program called Statistica version 13.3, and as I had to compare both continuous as well as categorical variables, I had to obviously use different kinds of tests. So for continuous variables, I've used the Mann-Whitney U test, and for categorical variables, I've used the chi-squared and Fisher tests. And now, something we have all been waiting for, I hope. So, results. We have analyzed data of 115 patients. The median age of those patients was 62 years. Out of the whole group, 51 were female and 64 were male. We discovered that from the whole study sample, 29 patients had positive urine culture. And I wanted to illustrate my point by showing you this pretty charming graphic with bacteria. So the most common pathogen that was isolated was Candida glabrata, with Acinetobacter baumannii on the second place. Other pathogens that were isolated from the samples were Klebsiella pneumoniae, Escherichia coli, Enterococcus species, and also Proteus mirabilis. We discovered also there was a statistically significant difference between those two groups of patients, and I mean culture positive and culture negative patients, for parameters such as BAN, yeast, and also urea. But we have also observed that there was a borderline difference for parameters such as urine leukocytes and immunosuppressive therapy. So, as you can see, we also saw that that the presence of leukocytes in urine may indicate culture positive results in some patients. Immunosuppressive therapy was not relevant in this study. Okay, so let's take a moment to look at this graph. So as you can see, the median of urine leukocytes for culture positive patients was much higher than for culture negative patients. Okay, so we have also observed that in the urinalysis of patients with a segment yeast present, there was a much higher rate of culture positive results, suggesting a possible correlation between those two parameters. And I have to go back because BAN and blood urea were our secondary parameters that we analyzed during our study, but they can be influenced by many factors. And as you can see, they can also be elevated in patients with UTI. So now let me sum up some things. So majority of urinalysis parameters may not have predictive value for culture positive COTI. We've discovered that the only urinalysis parameters that could be useful for its detection may be urine leukocytes and sediment yeast. So here are the sources that were used by us. As you can see, there are lots of them because we have 2 slides. And here is the picture of our group working together. So that brings me to the end of my presentation. Thank you all for your attention.
Thank you very much for your presentation. Now it's time for our questions for our committee.
First of all, I'm used to during the student conferences. I'm used to the fact that you are showing lots of, let's say, additional things on your slides apart from the pure scientific content. You are showing the pictures, the funny, descriptions of some things, and I'm a fan of a very rough form of this presentation, and I'm used to the fact that there are lots of these things during students' presentations, but during that particular presentation, it was a little bit excessive. That's one thing. I would like to ask you. Well, first of all, your aim. To criticize the aim of your study, because it's wrong. You cannot write the aim as the aim that catheter-associated urinary tract infection is a common thing, and that the diagnosis is challenging. Well, this is not the aim. The aim, in the aim, you should state what is the aim. Why did you undertake this study in the first place? Second thing that I would like to ask you, when the specimens have been taken from the patient, because you are trying to add this information to the fact that the patient had a positive sample, right?
Right.
But it is not the only factor, because the patient, when you are taking the blood results, maybe in a worse condition or in a better condition, it is not that easy to find out, to establish that the problem is associated with one issue only, with the fact that the urinary culture is positive. The patient may be in shock at that time, or it may be in a quite good general condition, and this is also very important. So that is a bit risky, this issue, and the fact that leukocytes were higher in the urine when there was a tract infection. This is a kind of an expected finding, isn't it?
Yeah, it is.
A very expected finding, I would say. So these are my comments. What would you say?
Thank you. So that was not shown on the slides, but we also analyzed a little bit more data, but the statistics were not significant. For example, it was for leukocytes, neutrophils in blood, and some other, I think, because there were lots of things we were analyzing during the study. But we wanted to just focus on things that were significant or were on the borderline. So yeah, about the condition of the patients, that might be problematic, I know, at this moment. We also analyzed, we took into account if the patient was on a immunosuppressive therapy, as was said, if they were diabetic, for example, and something more, I think. Would you like to contribute? Yes, antibiotics were also taken into account, and that's it, I think. Thank you for your comment.
Okay, may I ask 2 questions? My first comment is that Baumani should be with double N when you describe it on your graph or on your page. on your table. My first question is, what kind of immunosuppressive therapy was used? How did you define it?
We defined immunosuppressive therapy as the usage of both chemotherapy and also steroids.
But what dose of steroids was used? Was it a permanent use in chronic patients according to chronic conditions, or it was given to patients as a concomitant therapy in sepsis or something like that?
Mostly, there were patients with a longer use of immunosuppressive therapy.
What dose of therapy? What dose and what type of drugs was used?
Well, we don't really know the dose, if I'm going to be honest, because we didn't take that data.
Not good, because I think that you covered all steroids in your analysis, which is wrong, and it is not a real immunosuppressive therapy. And my second question is, did you make any differentiation between colonization from infection? As you know, positive urine sample is not an infection. And how many patients had real infection? How many patients were treated due to infection in terms of what you found?
Let me think a little bit about this.
Could you move back to some slides relating types of infection?
It was the
Oh, okay. The second one. Yes, because the majority of patients, according to your slide, was infected with Candida glabrata. I am not sure if all of these patients were really infected, or it was just a colonization. And what was the issue? Because the number is really huge, and how many of them were treated due to this infection? Because if it was infection, it is different than it was colonization.
I think we have checked that if they were treated for this, because if they weren't treated, then it means it is just a colonization, you know. And if they are treated for this, it will be just, you know.
I really think you should check this data twice or sometimes more, and make a real differentiation between infection and colonization. Okay?
Okay, thank you.
The last question. Actually, the Professor Krzych asked this, but I have to again ask the question, because you should put the aims very clearly, so we know what is the aim of the study. As I understand this study, and I can be wrong, sorry, that you have all the patients, all the population had the urinary tract infection.
Yes.
So based on what criterion, and you then want to check if there are any parameters, the biochemical, the urinalysis parameters that can be associated with culture positive infection. Okay.
Mm-hmm.
Yes, this is the aim. Yeah. Okay. Yeah. So you have to state it very, very clear to make it easy to understand the aims of the study. Okay. So if this was the aims, I think that the study is not bad, because as you show that the culture positive and negative do not have any predictable variables that we can deduct based on the parameters, that this will be culture positive or culture negative. Okay, so
right. Okay,
make it clear.
Thank you.
Thanks.
Okay, like we had to divide our group into some parts, mostly because there were also many confounding factors, such as the antibiotic therapy that can lead to the culture negative results.
So what were the criterion of the infection, of the urinary tract infection? Because as Professor Krzych said, some of them may be just decolonization, yeah?
Yes, I know. We basically used the criteria of culture, positive or negative results, I'm going to say.
And during the ICU study of our patients, we monitored because there were not only one sample for culture positive, but in some patients there were more than one. So the final one often came negative. So we just take this into our consideration that that might be also COTI positive patients.
Thank you very much for the comments, for the questions, and for your presentation.
Okay, thank you very much.
And now it's time for the last presentation of this session. It's titled Demographic and Clinical Characteristics of Organ Donors After Fatal Poisonings.
Good morning, esteemed jury, dear audience. My name is Julia Lipina, and today I've been honored with the possibility to present you work of my team on the topic of demographic and clinical characteristics of organ donors after fatal poisonings under the supervision of Professor Łukasz Krzych. Before I introduce you to the topic furtherly, I would kindly ask you, because we're all really connected to the big numbers, we take the weight in the big numbers, thousands, millions, billions. I would kindly ask you to imagine 1 in 5,000. How small is that in your mind? And keep it until the end of the presentation. The statistic says that there's 157,494 transplants performed in the year 2022. In Poland alone, the number was 1,503, and there's a constant list of around 8,000 to 9,000 people awaiting for the transplant. Each year in the Polish Transplant Organization, there's 700 potential organ donors registered, but only 500 of them becomes real donors. As of the poisonings that are also in the topic of the presentation, there's 80,000 deaths caused by the poisoning each year worldwide. So the aim of our study was thorough examination of the demographic and clinical characteristic of donors of organs and tissues following poisonings that have affected in death in Poland. As of material and methods, we used Polish transplant database in period analyzed from January 2022 to December 2022. And we only considered the deceased donors of transplants whose direct cause of death was stated as a poisoning. Exclusion criteria was different direct cause of death. So for example, if the patient was under the influence or the methanol was detected by the time of death, but he, for example, died because of the fall of height, we excluded them, and lack of consent for organ harvesting. So our study included in this 2-year period 38 donors after fatal poisonings total, including 17 females and 21 males, with average donor age of 40, ranging from 14 years old to 66 years old. The thing that we found is that most fatal poisonings in our donors were caused by methanol, as probably it's the easiest to access of the poisons. Other alcohol, including ethanol, were two deaths. Synthetic stimulants like amphetamine, 4 deaths. Opioids, including opioid drugs, not only for recreational use, it was 3 patients. Psychiatric drugs like benzodiazepines, 6 patients. The carbon monoxide, 1 patient, and other causes like cocaine, or when the cause was unknown, was the case of 5 patients. So as of the organs harvested, there were 14 hearts harvested, 26 kidneys en bloc or separately, 12 livers or liver parts, 10 lungs en bloc or separately, 20 cases of harvesting eye tissue like retina, and 5 cases of skin harvest or other organ, like for example pancreas. In 10 cases, the harvesting was dropped due to organ pathology, but in 3 cases, the harvesting was partially dropped due to delayed lack of consent for harvesting particular organ. For example, we've noticed that families tend to disagree, for example, agree for the kidneys harvesting, but they disagree for the skin or the eye parts harvest. So that leads us to the conclusion. I would like you to remember about the 1 in 5,000. That's how many people need transplant. It seems really small, and we might say insignificant when it comes to statistics. But imagine that 1 person in 5,000 is someone close to you. Your sibling, your mother, your father, your best friend. Does it seem significant at all right now? And thanks to the poisoned organ donors, we saved 88 lives. 88 patients received new chance at life thanks to the organs harvested from poisoned donors. So we can conclude that as they might not be the biggest group in organ donors, they are really valuable group of organ donors for us. Thank you very much for your attention. And now I'll be pleased to answer any questions.
Thank you very much for your presentation.
Well, I think you don't have to convince us that organ donation is important. We know that very well. But it's well, it's a nice study, and I would like to first of all, I would like to ask you one thing which I'm just interested in. It is fascinating that you have gained an access to post-transplant database. How is possible? Because this opens a gate for enormous research possibilities.
Yeah.
I would like to ask you some quick questions, but this is the first one, so just please answer.
Okay. So actually, every hospital performing transplants has their own post-transplant coordinator.
Yeah.
And thanks to the kindness of coordinator in SCCS in Zabrze, SCCS in Zabrze, she, under her supervision, we were able to look through the database. So she kind of was present at all times, and she gave us only partial access to the patient, to the donor's cards.
That means that the data in the post-transplant database are available for research, yes?
Yes, they are available for research. We needed, first of all, we needed the hospital president allowance, and then post-transplant allowance for the database. But they are valid for transplant. There's actually a lot of information that I couldn't include here due to the short form that could be acquired from the database. And I think that the analysis of post-transplant database might be really valuable to us, and not only in terms of harvesting organs, but also in terms of talking to the potential donor families so that we can increase the number from 500 to, for example, 600. Maybe one day every potential donor will become, by consent, a real donor. And I think I didn't even know that there's no knowledge that post-transplant database is inaccessible.
Well, it's every time I feel that we as physicians have an access to a large database, I have that funny itching feeling, which seems that we may have a great research in front of us as the anesthesiologists, right? But I would like to. So the next question is what was the total amount of organ donation roughly in that period, and what was the percentage of patients with poisonings among them?
The percentage was really low. We've estimated it because to see if the potential donor.
It was a rare cause of organ.
I wouldn't, maybe not that rare, but unusual. As you see, as I said, in year 2022, included in our study, there were 1,503 transplants performed in Poland. So if we roughly put 2 years together, it will give us 3,000, and there were 38 donors. So.
But are you at least able to say what is the percentage of patients with poisoning among those? Is it 1%, 5%, 10%?
Around 1.5%.
1.5%.
Counting.
So it means that in the database, the amount of donations that you would be able potentially to analyze is how much? 30. Around 3,000.
Around 3,000, yeah. That's how it looked. Of course, the database also includes potential donors, as I said. So, for example, at first, when the death was pronounced, doctors didn't know, for example, about the lack of consent of patient or their families. So they were qualified, but then family came in and said that they don't agree for the transplant, or that that was not the wish of the patient. So I would say that the database is huge. Like, we've only came to to collect these 38 donors. It was like page 28 out of hundreds.
Super. So you leave me very excited, because that means we have a huge source of information for many different types of research. Yeah. In general. Thank you.
Thank
you. Okay. If I may comment, because you said something that the family gives consent. So in Poland, we never ask family for consent. We ask family members if they know what were the wishes of the patient, of the organ donor. You should never start discussing this topic with family, starting with, are you okay with this, what we gonna do now to retrieve the organs? The first question, apart from giving, saying sorry, etc., is to ask if there were any discussions on this topic with this person. And if not, we should, how to say it in English? We should, no, that's not what I meant. We should assume, sorry, thank you for that. We should assume that if the person, there was no discussions about this, the person hasn't registered objection centrally in this register, we should just go ahead with this, yeah?
Yes, that was like, a quick detour to...
Because, many people forget about it. It's not family's consent. It's not family's consent.
Inappropriate wording, but the cases I meant by the lack of family consent were the situation where everything was fine up to the point where they said, for example, if they didn't want, for example, the eye, because that was the most common case. They didn't want the eye tissues to be harvested. they said, yeah, he said that we can take his heart, we can take his lungs, but he said that don't take my eyes, for example. So they kind of word it in a way that blocks us from it, but we have no way of verifying if that's just their reflection on the topic or the donor reflection on the topic.
But something that you probably wanted to say is you have to clarify everything. It's worth to spend lots of time with the family to explain how it would look like how the body would look like after harvesting. That it won't be visible, you know, because families might have these concerns about it, and then they will probably say, no, this person didn't want to take his eye, corneas, etc. So it's worth to discuss it, to explain it, how it will be, how the body would look like. And my another question, if I have a microphone, these eight cases that the organs weren't retrieved were actually pathologies found during the retrieval procedure? That's what you meant by eight, because there were 8 cases. Withdrawal from retrieval occurred. Withdrawal from retrieval, so there was no retrieval in 8 individuals, primarily due to identified organ pathology.
Yes.
So it was identified during the surgical procedure, and it was before.
Unluckily, I don't have that kind of information. The information that appears is exactly what we said: withdrawal from retrieval due to organ pathology. So we don't have further information. We looked in the database if there's any comment on that, but unluckily we didn't find anything like that.
Okay, thank you.
One more thing about this family consent. So you had pediatric donors as well.
Yes.
So what's the case? Because that's the one point you can defend yourself talking about family consent in this kind of study.
Yeah.
How it is about pediatric population?
When in the pediatric patient, we need to consider the legal guardian's opinion on donations.
We need, or we had to?
We have to.
Who gives the consent for the pediatric donation?
Legal guardians.
That's the major point.
Legal
That's the major difference.
And as far as I'm concerned, it must be both legal guardians of a children by the time of death. We actually had cases when one of the legal guardians agreed and the other one denied, so we had to exclude the patient from potential donation.
What I am really curious about is there a change in donations before and after the 2019? So you have analyzed the 2020-22, so it's the new guidelines. 24, sorry. Yeah. So these are the new guidelines. It's not just the discussion, because I think that the years before 2019, where we had the older guidelines, especially in terms of intoxication, may be lower than current donations. Okay, so I think that we have some tools, which we didn't use them as much wcześniej. But for example, a CT, the computed tomography of the brain perfusion, so you can easily assess the brain functions in the patient who is intoxicated without waiting some period of time. So this is the huge change in the qualification to donation. So maybe it will be interesting to compare the years before the new guidelines and after the new guidelines, or if the new guidelines increase the number of donations. It's just my thinking about the topic. This can be interesting.
Okay, thank you very much for that. That's a really good idea to extend the study. However, we've noticed when you said about the change, I thought that you're going to ask about COVID-19, because we've noticed that in the time of the lockdowns, there were higher rates of poisoning by methanol, indicating that even the loneliness might be the factor contributing to fatal poisonings as a cause of death.
Sorry, last comment. I need to comment on this because your English is brilliant, and I must congratulate you on this because the presenting was brilliant. So really
Thank you
nice.
very much.
All the submitted papers have been presented. I congratulate all the presenting authors and participants of the Anesthesiology, Intensive Care and Emergency Medicine session. At this point, I would like to ask the Professor Knapik for a few words to sum up the session.
The question is, should I keep talking in English, or być może moglibyśmy przejść na język polski, bo można mieć wrażenie, że jesteśmy naprawdę za granicą w jakimś dobrym researchowym ośrodku. Szanowni Państwo, no ja ze swojej strony mogę powiedzieć tak. Ja obserwuję sesję STN-u przez wiele lat i jestem naprawdę zbudowany tym, co widzę w dniu dzisiejszym. Poziom idzie nieprawdopodobnie do góry. Ja pamiętam, jak to było na samym początku, gdzie te prezentacje były takie toporne, różnie to bywało. Prezentujący nie potrafili, już nie mówię mówić po angielsku, ale pokazywali na slajdach te przeskakujące ludziki, animacje i to była główna treść. Tak często było na początku. To jest już w tej chwili przeszłość. Poziom naprawdę tego, co ja tutaj widziałem, jest znakomity. Jestem bardzo zbudowany tym, co widzę. No pewnie jest to związane w znacznej części głównej też z tym, że prace były przygotowane pod okiem znakomitych nadzorujących, więc tutaj nie było żadnych słabych punktów, żadnej lipy. Naprawdę fantastyczna sesja. Można by naprawdę, mówię to zupełnie w tej chwili szczerze, nie musielibyście się Państwo wstydzić na żadnej zagranicznej konferencji, prezentując pracę w taki sposób. Może tylko taka moja rada, jestem może starej daty i to stąd to mówię, prezentacje naukowe powinniście, ja wiem, że jest taka chęć, takie poczucie, że to trzeba, ale trzeba wyciąć z nich wszystkie ozdobniki, pozostawiając jedynie treść naukową, bo to są tak zwane dystraktory dla człowieka, który ogląda prezentację. Wszystko, co jest na ekranie i co nie zawiera danych, to są dystraktory. Pamiętajcie o tym, żeby wszystkie opisy, wszystkie legendy były wielkie, czytelne, proste, bo człowiek, który to widzi to po raz pierwszy i musi w sekundę zorientować się, o co chodzi, bo już przechodzi następny slajd, więc musicie Państwo tworzyć te prezentacje pod oceniających, pod oglądających, pod swoją publiczność i ten przekaz dla publiczności musi być jak najbardziej prosty. Ale tak jak mówię, poziom tej sesji jest dla mnie imponujący. I mówię to szczerze, nie dlatego, że chcę Państwu zrobić przyjemność, tylko po prostu poziom tej sesji jest tak wysoki, że nie ma się czego wstydzić. Nie byłoby się czego wstydzić na zagranicznych gremiach. Poziom języka angielskiego również. Także dziękuję bardzo. Była to dla mnie wielka przyjemność tego posłuchać.
Dziękujemy bardzo Panie Profesorze za te słowa. Kwestia jeszcze kilku kwestii organizacyjnych. Ceremonia zakończenia, gdzie zostaną ogłoszone wyniki dzisiejszej sesji, odbędzie się dzisiaj o godzinie 18, nie tak jak zawsze na auli A3, tutaj na kampusie, tylko w kinoteatrze Rialto. Zapraszamy bardzo chętnie, również komisję. Zmiana lokalizacji wynika z tego, co pominąłem na początku sesji, że jest to nasza okrągła 70. edycja konferencji, dlatego zapraszamy wszystkich jeszcze raz na godzinę 18 do kinoteatru Rialto. Wszystkich uczestników oraz komisję zapraszam również na godzinę między 12 a 13 na lunch, który odbędzie się przy głównym hallu przy auli A3, tam gdzie była rejestracja. Z mojej strony to wszystko. Uważam sesję za zamkniętą. Dziękuję bardzo.